Welcome back to the deep dive. Today we're cutting through the congestion, diving into something super common, maybe misunderstood, the sinus infection. Acute rhinosinusitis, technically.
Right. And we're looking at the latest guidelines, the NHG standard, fresh from May 2024. This is really the benchmark from the Dutch GPs.
Version 4.1, okay.
Exactly. And our focus is clear. Diagnostics and treatment for when you've had symptoms for less than 12 weeks.
And let's just start with the biggest takeaway, because honestly, this might change how you think about it entirely. Acute rhinosinusitis, it almost always gets better on its own. It doesn't really matter if it's viral or bacterial. The natural course is just incredibly good at serious problems.
Yeah.
Super rare.
That really is the core message from the evidence. The body's got this, usually, which means we shift away from, immediately reaching for treatments and more towards explaining things and managing how you feel.
Okay, so let's get specific then. How do these guidelines actually define ARS? What are the symptoms we're talking about?
Okay, so clinically, you need a runny or blocked nose. That's the first part.
Right.
Plus at least one other main symptom. That could be pain or pressure in your face, or maybe you notice you can't smell things as well.
And the timing is key.
Absolutely. Less than 12 weeks maximum for these symptoms.
Yeah, I always think of that specific pain, that sort of heavy feeling right in the face.
Exactly. And the guidelines mention it can feel like it's in your teeth or gums sometimes. And the classic sign, it gets worse when you bend over.
Ah, right. That pressure change.
That's tied to the inflammation blocking things up in the sinuses.
What about for kids? Is it different for them? I imagine checking sense of smell is...
It is, yeah. Basically impossible for young children. So for kids, the alternative symptom is cough. Day or night, doesn't matter.
Okay, cough instead of smell.
And remember, very young kids, their sinuses aren't fully formed yet. Only the ethmoidal sinus is really there at birth. So for them, it's mostly just nasal symptoms, like a really bad cold.
That makes sense. Presentation's different. Okay, zooming out a bit, how common is this overall?
Well, in general practice, they see about 30 cases per 1,000 patients each year. It's pretty common.
30 per 1,000. And I saw something interesting about who gets it more often.
Yes, quite striking, actually. It happens about twice as often in women compared to men.
Twice as often.
Yep.
Wow. Okay, so let's shift to the cause then, because everyone feels those symptoms and thinks, it must be bacterial. I need antibiotics. Is that right?
It's mostly... not right, no. The huge majority start as a viral infection in the nose, like your typical cold that just hangs around or gets a bit worse.
This viral?
Overwhelmingly. When you look at all upper respiratory infections, the chance of a bacterial complication setting in is tiny, maybe 0.5% to 2%. Really low.
Okay, 0.5 to 2% is incredibly low.
Yeah.
But you also mentioned a figure, I think it was around a third, for people who actually go to the doctor. How do those fit together?
Right, good point. So the 34% figure, that's for patients presenting to the GP with ARS symptoms. It's a different group.
A sicker group, presumably?
Exactly. If you feel bad enough to go see the doctor, you're more likely to be in that subgroup where bacteria are involved. But, and this is crucial, even when it is bacterial.
The body still usually clears it?
Very likely, yes. The natural resolution is still the most probable outcome.
Okay, and if bacteria are the issue, who are the usual suspects?
The main ones are Streptococcus pneumonia, that's about a third, and Haemophilus influenza, also about a third.
Strep pneumonia, H flu, okay.
Yeah. Then you get smaller amounts of things like Staph aureus and Moraxella catarrhalis.
But even with those bacteria potentially present in, a third of people visiting the doctor, the main point stands. It usually gets better by itself. How much better?
Incredibly well, actually. Symptoms usually start easing up within days, maybe a week. And for adults, something like 90% are completely symptom-free after 3 weeks.
90% without specific treatment.
Exactly. Whether they got anything specific or not, the body just sorts it out.
And what about the scary stuff? People worry about it spreading, like to the eyes or brain. How often does that happen?
Vanishingly rare. The estimates are about 1 complication per 96,000 adults.
96,000.
And maybe 1 in 36,000 for kids, still extremely uncommon. And knowing these numbers is so important because it argues against using potentially harmful treatments routinely.
Right. If it gets better on its own almost always, and complications are that rare, it completely changes the diagnostic approach, doesn't it?
Yeah.
I assume no fancy tests.
Precisely. The guidelines are very clear. Diagnosis is based on listening to the patient, the history, the anamnesis, and a basic physical exam. That's it. In primary care, you don't need more.
That's almost hard to believe sometimes with how test-heavy medicine can be. What about blood tests like CRP? That measures inflammation, right? Why not use that?
It measures general inflammation, yes, but the evidence review found it just doesn't help here. It can't reliably tell you if it's viral or bacterial in a way that changes what you do.
Really? Even a high CRP?
Even a high CRP, say over 25 millirolers. Studies show that wasn't a good predictor of who would actually benefit from antibiotics, so the test doesn't guide the therapy.
Okay, no CRP. What about imaging? CT scans, X-rays, people sometimes really push for those, convinced they have something serious blocked up.
Also not recommended. Same reason, really. An image showing inflammation doesn't reliably pick out the patients who need antibiotics.
Wait, so even if a CT scan shows inflamed sinuses, it doesn't mean antibiotics are the answer or will work better?
Correct. The evidence simply isn't there to support it for routine ARS, and when you consider the condition usually gets better anyway, plus the cost and radiation from CT scans.
It just doesn't add up.
Exactly. Diagnosis is clinical, history, and exam.
Okay, that really sets the stage for treatment then. If we don't need tests, and the body handles it.
Yeah.
Why are antibiotics still prescribed so often? You mentioned about half of patients in practice get them.
Yeah, it's a persistent issue. Prescribing habits just change slowly. The data shows they're often not needed and can even cause harm, but the practice hasn't fully caught up everywhere.
Let's drill down on that trade-off. The benefit versus the risk. You mentioned some stats, NNTB and NNTH.
Right. So NNTB, that's the number needed to treat to benefit. For antibiotics and ARS, it's 18.
18. So you have to treat 18 people with antibiotics for just one extra person to be cured maybe a bit faster, like within 14 days, compared to just waiting.
That's exactly what it means. A very small potential benefit for one person out of 18.
Okay, now compare that to the harm, the NNTH.
The number needed to treat to harm NNTH is just 8. 8. In the studies, about 27% of people taking antibiotics reported side effects, stomach upset, diarrhea, thrush, that kind of thing.
So you're more than twice as likely to cause a side effect as you are to provide that small extra benefit much later on. That's stark.
It is. It really should change the conversation with patients.
Absolutely. And if antibiotics are genuinely needed for those exceptions we'll get to, are there specific ones to use or avoid?
Yes. Resistance is a big concern.
Right.
So macrolides, like azithromycin, they used to be common, are now generally not advised first line because of growing resistance.
Okay, so no Z-Pak generally. What's first choice then?
If you really need one, it's amoxicillin, usually for about a week.
This really comes back to talking to the patient, doesn't it? Explaining all this. How much does good information help compared to just giving a script?
Hugely. This was a fascinating finding. Patient satisfaction. It's much, much more strongly linked to getting good information and feeling reassured.
How much more?
The odds ratio was 10.6. That's massive.
10.6. Compared to
actually getting an antibiotic prescription, which had an odds ratio of only 2.2, especially if the patient wasn't really expecting one anyway.
So talking and explaining is literally 5 times more powerful for satisfaction than the pill itself.
Pretty much. Managing expectations, reassuring people about the natural course, that's the most effective tool we have.
Okay. So if antibiotics are usually out, what should people do to feel better? What are the recommended non-drug approaches?
It's all about symptom relief. Making yourself more comfortable while your body does the work. Saline solutions drops or sprays can help. Steaming can, too, for nasal congestion.
But these don't speed up recovery.
No, they just help you feel better along the way, which is important. But they don't change the underlying course.
And the warning about steaming is critical.
Absolutely critical. If you steam, the water must be no hotter than 60 degrees Celsius, max. Serious burns are a real risk otherwise.
60 degrees C. Got it.
And no menthol or similar things for kids under 2. Risk of airway issues.
Okay. What about pain? That facial pain can be rough.
Definitely. Simple painkillers are key. Paracetamol's first choice, or NSAIDs like ibuprofen if suitable for the patient. Manage the pain.
Right. Now, nasal decongestant sprays, the ones with thiametazole or oxymetazoline, they work fast, but there's a catch, isn't there?
A big catch. You absolutely must limit use to 7 days maximum.
Only a week. Why?
Because if you use them longer, they stop working as well, and you can get changes in the nasal lining that lead to worse congestion when you stop. It's called rebound congestion or rhinitis medicamentosa.
Okay, 7 days max for adults. But the real high alert is for little kids.
Yes, huge caution needed there. The advice is strongly against using these in children under 2 years old.
Why so strict?
Because there's a risk, though rare, of quite serious side effects in infants. Things like irritability, slow heart rate, even apnea, seizures, coma have been reported. It's just not worth the risk unless in very specific, severe situations, maybe like if they can't drink properly.
Wow. Okay. Under 2, basically avoid unless absolutely vital. What about slightly older, say 2 to 6?
For that age group, maybe consider it, but only if saline hasn't worked and the symptoms are really bothering the child significantly. It's still a second or third line thought.
Okay, so be super careful with decongestants in kids. Now, we've hammered home that most cases get better, but there must be times when you do need to act, maybe with those antibiotics. What are the exceptions?
There are clear criteria. You'd strongly consider antibiotics if the patient is seriously ill, just looking generally unwell, systemically sick.
Okay, seriously ill. What?
If they have reduced immunity. That covers a few things. People on long-term oral steroids, maybe someone with HIV and low T-cell counts, poorly controlled diabetes, or even just frail elderly people who seem quite unwell with it.
Right, compromised immunity. Any other triggers?
Yes, fever pattern is important. If they have a fever that lasts more than 5 days straight,
Look for 5 days.
or interestingly, if they had a fever, it went away, and then it comes back again during the same illness episode, that recurring fever is a flag.
Okay, so seriously ill, low immunity, or that specific fever pattern. What about the prescription steroid nasal sprays? When might they be useful?
They have a different role. You'd only really consider intranasal corticosteroids if the symptoms are just dragging on, unchanged, after about 14 days.
2 weeks, no better.
Right. Or if someone gets frequent recurrent episodes. The definition often used, especially in the US, is like 4 more episodes a year with symptom-free periods in between. If it's dragging on or coming back often, it might suggest more chronic inflammation where steroids could help.
Got it. Finally, the really critical part. The alarm bells. The red flags that mean this isn't just a sinus infection anymore, it's spreading. When do you need immediate urgent referral?
Yeah, these are crucial. Immediate referral to a specialist is needed if you see any sign the infection might be moving outside the sinuses.
Like what? What are the signs?
Think eyes and brain mainly. So any sudden vision loss or double vision, pain specifically located in one eye, if the eye starts to bulge forward, that's proptosis or exophthalmia.
Okay, eye changes.
Swelling around the eye, eyelid swelling or swelling of the white part, the conjunctiva, which is called chemosis. Also swelling on the forehead, right over the frontal sinus.
Start to swelling. Yeah.
A really severe headache that's different or worse than usual sinus pain. And any neurological symptoms, confusion, drowsiness, seizures, stiff neck, anything suggesting brain involvement.
Those sound serious.
Yeah.
Immediate action needed.
Absolutely. Those are medical emergencies.
Wow. Okay, this deep dive has really shifted the perspective, I think. The evidence just points so clearly towards doing less, intervening less.
That's the synthesis, exactly. Trust the natural course. Default to education, reassurance, symptom relief. Keep the diagnostics and the antibiotics for those specific rare situations where the risk calculation changes.
So for you listening, ARS mostly gets better by itself. Tests, usually not helpful. Antibiotics, rarely needed potential harms. Decongestants, use carefully, especially in young kids. And know those red flags for immediate referral.
Right. And maybe a final thought to leave you with. True recurrent acute rhinosinusitis, meaning you get fully better between episodes, like 4 times a year, is actually quite rare.
Really?
Yeah. So if you feel like you're getting sinus infections over and over again, it might not be separate acute episodes. It could actually be flare-ups of an underlying chronic rhinosinusitis that hasn't been diagnosed.
Ah, so it's more of a constant background issue flaring up.
Potentially. So if that sounds like you, maybe the next step isn't just treating the acute flare, but exploring if there's a chronic sinus health issue to manage long term. Something to think about.
A very interesting point. We'll leave you with that thought. Until next time on The Deep Dive.